All right. Now we're going to move into the last part of the lecture, which is extensive, but also really where the heart of OT's work is with folks who have had a TBA. And this is the Rancho Los Amigos scale of cognitive functioning. It's often referred to as the Rancho levels, or RLA. And Rancho Los Amigos is in California, in Downey. This is a picture of the center. It's all state of the art and very sophisticated, and a lot of rehab happens there. So I want you to know this scale, and it is well, it's actually a 10-point scale, but we put 8 points on there because if the person is at a 9 or a 10, then they're doing really, really pretty well. I've included at the end of the lecture the levels 9 and 10, but OT typically would not be called in for someone who is functioning at such a high level. We're going to go through them one at a time, so they're just listed here for you, and yeah, we'll dig into each of them. So when we think about the recovery process of Rancho Los Amigos levels 1 to 3, we think about total assistance. Okay, so this is the lowest levels and the most involvement. Rancho Los Amigos levels level 1 is a coma. So the person is not arousable and not responsive. They have an absence of awareness of self and the environment despite maximum stimuli. So we can be providing painful stimuli, verbal stimuli, tactile stimuli, and they are not rousing to it. There's no periods of wakefulness in the coma state. RLA2 is a persistent vegetative state, or PVS. So again, there's no awareness of the self or the environment. They can't follow commands. They're not making intelligible verbal responses or communicating. There's no automatic motor response or localizing stimuli, and bowel and bladder are incontinent. The positive signs are that there are sleep and wake cycles. So contrast that with a coma where there aren't any sleep or wake cycles, right? And there's brainstem autonomic functions like gag, swallow, cough, and temp regulation. There also may be random vocalizations and random movements. So let's talk about what a vegetative state looks like. There's 2 different types. One is a persistent vegetative state. The other is a permanent or irreversible vegetative state. So in RLA2, we're looking at a PVS, or persistent vegetative state, which means that they've been in that state for more than a month, and it describes their past and their current state. Contrast that with an irreversible vegetative state, which is that they've been in it for at least a year, 3 months of a traumatic brain injury, or 3 months after a non-traumatic brain insult. We need to determine the level of medical support and nutrition that's needed, and advanced directives are helpful in this case, but they're rarely present. So this is the person that is not going to come out of this state and is not going to get well. It's a very sad situation, and yeah, and a very difficult one for the person's family, and you know, having them be in an irreversible vegetative state that is not going to change. So Rancho level 3, and now we're getting into the area where we're really going to be working with folks, is a minimally conscious state. So there's some awareness and wakefulness, They definitely can reproduce some awareness of the self or of the environment in the following ways. They can follow commands. They can have gestures or verbal response to questions. They're intelligible sounds as opposed to unintelligible. They may cry, laugh, or smile with relevant stimuli. They may reach out or hold objects, and they can track with their eyes. Now, this is still a total assist state, right? As we noted with RANCHO levels 1 through 3. So even though they're a little bit more wakeful and aware, they're still at a total assist. I want to spend a minute talking about something called locked-in syndrome, which goes with RANCHO level 3. It's a loss of voluntary motor control in a setting of preserved consciousness. So while the person cannot move at all, inside their brain, they actually are conscious, but they can't do a lot to indicate that consciousness. There is tetraplegia, which is also known as quadriplegia, and it's paralysis of the upper and lower body, affecting both the arms and legs, and signs of bulbar weakness. So bulbar palsy is accompanied by difficulty swallowing, weakness in the jaw and facial muscles, of course, no speech, things like that. But there is vertical eye movement and blinking. Those are a couple of the only motor signs. There's typically damage to the corticospinal and corticobulbar pathways, and the lesion is in the basis pontis classic. It may be difficult to demonstrate conscious behavior because of the motor limitations. So important for you to know about, do you need to know all of the details of it and what the tracks and pathways are? No, just a general idea of what locked-in syndrome is. I found this image and it was really interesting. It shows 4 different states of consciousness. If you look on the upper right with the vegetative state, there's really not very much activity at all, as evidenced in that light purple triangle. Then there's a minimally conscious state where there's a little bit of activity going on. That's the lower right. In the lower left is locked-in syndrome, which we just discussed. And notice how much brain activity is going on. But contrast it with conscious control, where that red area is totally filled in and there's so much more activity happening, and it's activity that is happening both in the motor systems and in the cognitive systems. So just an interesting visual of those different states. Let's move on to musculoskeletal problems. So we want to be aware of fractures, and we want to clarify weight-bearing parameters and what they could do before admission to the hospital. Now, this would be particularly relevant with someone who is older, who may or may not be particularly solid before they got the TBI and came into the hospital. So we want to be sure that we're up on those precautions and weight-bearing parameters. We also want to be aware of something called heterotropic ossification. That is when there's an abnormal bone growth in the soft tissue. So the bones are actually overgrowing, and there's calcium deposits being laid down. It typically happens between 2 and 8 weeks after the injury, and it's usually detected either by therapists, nurses, or families. Because the person is less and less able to engage in voluntary movement. X-rays and bone scans can identify it, and what we do is give NSAIDs, which are anti-inflammatory drugs for pain and inflammation, and a drug called etidronate for helping to stop the laydown of those bone deposits and to kind of halt the progression of this issue. We also want to engage that person in continuous passive motion. So we want to move the joints and the limbs as much as is possible, because that helps with the lay down of bony material. All right, and then we're going to look at wheelchair positioning goals for a person who's in levels 1 to 3. It's not so much that we want to give them a way to ambulate independently, right? Because they're totally dependent. But what we do want to do is put them in a position to help prevent deformity, to normalize their tone, to manage their pressure, remember the decubitus ulcers, to promote function of whatever level they're at, to increase their sitting tolerance, because we know that laying down is not good long term, right? So, and it also really precludes you engaging in functional activities. Also to enhance respiratory function. So if you're laying down all the time, your respiration is it can't work as well, right? If you're sitting up, you have much more lung capacity. You can fill your lungs more easily. You're not, all of those things. And finally, to provide proper upper body mechanics. So people are made to engage with their upper extremities while we're in a sitting position. Of course, you can do it in bed, but it's not as easy or effective. So all those reasons really push us to see how we can very well fit a person in a wheelchair. And this drawing shows people in a lot of not very adaptive positions. And then the person that is in the bottom center is actually in a great anatomical position. This is something that you might encounter with our folks who are RANCHO levels 1 through 3, and it's a dynamic head positioning device. It provides alignment and also freedom of movement and promotes function. So if the client doesn't have great head control, this can be a very effective and adaptive tool for them. Another thing that we want to do is to manage spasticity. So spasticity is the tightening of the muscles, which may or may not be permanent due to lack of movement and also to neurological damage. So both of those things. We want to look at positioning in bed and chair. We want to look at sitting and standing opportunities, so perhaps in a standing frame. And this would require 2 people for treatment, right? One to manage the stand and all of the safety, and the other person to engage, the other therapist to engage with the individual. We're also want to look at neuromuscular blocks and casting. And in the presenter notes in your slide deck, there's a number of different drugs that are associated with neuromuscular blocks. They are phenol, bupivacaine, and botulinum toxin. And it's the same botulinum toxin that's used in Botox. But it does a really great job of paralyzing small muscles and releasing some of the spasticity. So all of those are for spasticity treatment, as is casting, right? So we're going to put a person in a more anatomically neutral position and cast them there to help with the spasticity. And then there's a range, again, in the presenter notes, of systemic medications that are used to help with spasticity. Alrighty. This is a visual that I found that shows you some different kinds of examples of spasticity: elbow flexion, wrist flexion, pronation, clenched fist, and a thumb in palm. So some nice upper body illustrations of spasticity. The question comes up for occupational therapists of when to cast a person as opposed to using some of the other treatment techniques. We cast when splinting has failed to control severe tone or contractures. So splinting is our initial go-to, and then we cast if splinting just isn't cutting it. We typically use a positional cast that is available for continued use. So it's a bivalve cast. As you can see in the picture, it's a split cast so that we can take it on and off. Range of motion is decreased when you're in a cast, and prolonged stretching is necessary. So it's not that we can just put a person in a bivalve cast and be done with it. We really need to continue the therapy to make sure that they're being ranged and that they maintain that range and and get movement outside of the cast. All right. So this is kind of a sad slide. What happens if you don't get treatment? Well, contractures, as we've talked about, and you can see in this photo that the gentleman has some flexion of his fingers. It looks like his thumb may be inside of his palm. There's limited head and trunk control. Increased caregiver assistance is necessary. There may be limited participation in daily activities, obviously, limited mobility, and difficulty with transportation. So a lot of things happen when there's not good intervention. Now we're going to move on to the recovery process for RANCHO levels 4 through 6, which are our levels where we consider the person to be confused. RANCHO level 4 is confused and agitated. And this person is alert, unlike our folks at levels 1 through 3, but they're often at a heightened level of activity, sometimes sort of a hyper level of activity. They may attempt to pull out their IV, to undo restraints, or to crawl out of bed. They don't have short-term memory. They may cry or scream totally out of proportion to the intensity of a stimulus. They could be aggressive or try to flee. And they have very big mood swings with no apparent relationship to what's happening in the environment. They require maximal assist. So you can see that a lot of this is what's going on inside their head is not commensurate with what's happening outside in the environment. What we're going to provide is a behavior management program. And we're going to provide an environment that motivates folks to participate in rehab to the best of their ability. We're going to pull family members into the team and develop the plan all together. And we're going to maintain a safe environment for that person throughout a multifaceted safety program. So behavior management goals for our folks at RANCHO Level 4. We want to minimize the use of all restrictive modalities. So we want them to be able to get out there and get better. We want to provide education to patients, family, and staff, and identify if the person has had a substance abuse disorder and initialize treatment for that abuse disorder. So those are some things that we're looking at. We also want to look at the environment because the environment is exerting a huge impact on the person that is out of line with what's really happening in the environment. So to that end, we decrease visual stimulation. We reduce auditory stimulation like a TV being on or staff communication happening around that person, and we provide a lot of consistency and structure. This photo is of a bed that is kind of enclosed, so the person can kind of reduce their agitation and have a safe and sort of more protected environment to be in. We also have a lot of different kinds of communication interventions. We want to model behaviors for the patient. We want to speak calmly, slowly, and in simple sentences so that they understand us. If they are agitated and want to walk, we don't want to restrain them, just walk with them because walking can often be calming. Give praise and attention when desired behavior occurs. Don't reinforce undesirable behavior. That means by bringing attention to it even. And redirect patients when they're agitated or perseverating. So perseverating is going around and around and around with the same thing. So we don't want to reinforce that. And we do want to provide that person with choices, good choices, whenever possible, because that brings a sense of control. All right. We're getting up there. Rancho level 5, confused, inappropriate, but here's the difference is that they're non-agitated, whereas our folks at level 4 were agitated. Level 5 is non-agitated. They're alert. They're not oriented to person, place, or time. They have frequent periods of non-purposeful, sustained attention. So they can attend to stuff, but it's not stuff that they need to attend to. They're unable to learn new things. They are able to respond to simple commands pretty consistently, especially when you were given outside cues, so some support. They're able to converse on a social automatic level for brief periods of time. Hi, Mrs. Jefferson. Hi, how are you? I'm good. How are you? Right? So that very ingrained level. They verbalize about present events, often in inappropriate or confused ways, and they still require max assist. Now we go to Rancho level 6, which is confused and appropriate. They are inconsistently oriented to person, place, and time, but they've got a little bit of orientation going on. Their remote memories are more accessible than their recent, so that has to do with the amnesia states. They're able to use memory devices with max assist. They need supervision for self-care tasks, even if it's stuff that they already know how to do. They do show some carryover for relearned familiar tasks. So that's really great in terms of learning and increasing the person's independence. They seem unaware of their impairments or their disabilities or the safety risks that are associated with the environment, and they require moderate assist. So we're decreasing the amount of assist needed as they increase their capacity. All right, we're getting to the end. Rancho levels 7 and 8, automatic, purposeful, and appropriate. Rancho level 7, they are consistently oriented. Yay. They have increased attention and they're able to work for 30 minutes on very familiar tasks. That's awesome. Minimal supervision for new learning. They can carry out familiar self-care and household tasks, but they might not remember it real well. They're not realistic about planning for the future. They may overestimate their abilities. They're not able to think about consequences. So now we're getting into really much more high-level executive functioning, right? They're not aware of others' needs and feelings, so very self-centered, and they require minimal assist for ADLs. Level 8 is purposeful and appropriate. So again, oriented, they can attend for an hour, up from a half hour. They can recall past events and integrate them with recent events. They can do familiar routines, and they can slightly change a plan when needed with minimal assist. So that's huge for a person's independence. They don't need assist once a new task is learned. They do need assistance to correct themselves when a plan needs alterations. It's not working this way. They need some help to figure out how to do it differently. They think about consequences and they acknowledge others' feelings and needs. They may, however, be irritable and depressed, and level of assist, standby, or supervision. These last two slides, as I said, are RANCHO levels 9 and 10. Typically, OT would not be involved here, but I included it just for your reference. So you can look at these. They're, I don't like too many words on a slide. This is a lot of words on a slide. So it's more for your reference than to ever broadcast as a slide deck. But I'm going to let you read about RANCHO Level 9, which is purposeful and appropriate with standby assist on request. And then RANCHO Level 10, purposeful and appropriate, modified independent, which is our highest level. So please do download the slide deck and you can read about levels 9 and 10. Where we are really going to focus is around levels 4, 5, 6, 7, and possibly 8. So do know all the RANCHO levels, but that's our sweet spot for where we're going to focus. And that's what I got for today for everyone. So I hope that you have gotten some new information, that it's been intriguing to you, and please write down your questions and bring them to class. We'll be spending a whole day on traumatic brain injury, and I'll be happy to discuss it with you there. All right, and do check the Learning Management System for more resources as well. Thanks, everyone. Take care. Have a great day. Bye now.